Welcome back to Your Health radio and television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and my second guest today, anesthesiologist Dr. Alex Dubelman. Dr. Dubelman, thanks very much for joining us.
Oh, it's a pleasure to be here, Dave.
Appreciate you coming. Now, Dr. Dubelman, I want to get right to the point. One of the questions I hear from patients so often, most of the viewers and my listeners know I'm a plastic surgeon. Time and time again, I see people in the office who are happy to sign up for surgery, but they're so concerned about anesthesia and going to sleep, and is it safe, and who breathes for them, etc. Can we talk a little bit about the safety of modern anesthesia?
Absolutely. Anesthesia is, I hate to sound like a Jaguar commercial, but anesthesia is safer now than it's ever been. And it's much safer than when I finished residency 29 years ago. And there are a variety of reasons why. We have much better drugs. We have far better monitoring equipment. When I finished anesthesia, we didn't have pulse oximetry or capnography, so we were effectively like a pilot flying a plane by what they would call seat of the pants.
Right.
Now we have very accurate measurements of the oxygen in a patient's blood and his carbon dioxide. And
so let me interrupt you for just a brief moment. You mentioned a pulse oximeter and capnography, is that what you said?
That's correct.
So let's define those instruments, or let's define those measurements for our viewers.
A pulse oximeter is a little a clip that we put on a patient's fingers usually that tells us the exact saturation of oxygen in his blood.
So it can actually read through the skin and the fingernail to tell you how the patient's blood is doing, how the oxygen saturation is doing.
That's correct. 25 years ago, we would look at a patient's lips and decide, are they blue or aren't they? And if the light was down, it was very subjective. Now we can look up at a monitor that gives us a saturation which we hope will be 98, 99, or 100. And if it's not, we want to know why. And it's done by a complex algorithm that looks at the difference in absorbance of oxygen, deoxygenated and oxygenated hemoglobin.
I see. Now, Dr. Dubelman, I believe you came up here from the Los Angeles area.
That's correct.
From the UCLA training system, and I think you were a teacher, and I think you headed a department for a while.
Well, I was the chief of the department in Los Angeles, but I trained at UCSF.
I see.
Which was the finest training experience of my career.
So you trained at UCSF,
and
then you went to work in Los Angeles.
Yes.
And then came up here.
That's correct.
And I know that one of your areas of expertise is cardiac anesthesia.
That's correct.
Which I understand really is quite difficult, and only some of the elite anesthesiologists go on to do cardiac anesthesia. Isn't that right?
Well, I think it's more of a desire to do more complex cases. I don't know that it's elite. I practiced pretty much exclusively cardiac anesthesia for 12 years in Southern California. But I think that even, if you have patients that are not well, plastic surgery patients can be quite a challenge. Any field can be a challenge. So.
Right. So, Dr. Dubelman, before we go on, I have lots of specific questions for you, but I'd like to talk about, let's imagine we have a young listener or young viewer. What's the training like to become a board-certified anesthesiologist?
Okay. As Dr. Gerbino had alluded to before, we want to finish high school, that's for sure, kids. And we want to go to college, have a major, usually, but not always, in the sciences. But we know lots of doctors who are English majors or history majors, just as long as you've completed the prerequisites in science. Then you have to apply to medical school, and as Dr. Gerbino said, you want to do well on your medical college admission test. You go to a medical school and you apply to internship and residency. And in the case of anesthesia, there's a year of internship, 3 years of residency, and then if you're going to specialize, often there's another year.
Well, that's amazing. So after high school, it's 4 years of college, 3 or 4 years of internship residency, and then some anesthesiologists do a fellowship or additional training.
That's correct.
So, Dr. Dubelman, is it your choice to do cardiac anesthesia, or you like doing plastic surgery or different types of
well, I love all anesthesia now, but I really do prefer cardiac when I can do it. I like the challenge of getting the heart started again. I like the challenge of optimizing what we call the hemodynamics, which is the the amount of blood going in and out of the heart and how we regulate that. And in some ways, I like to think it's more challenging than the average case. But certainly, even the average case can become quite challenging when things go wrong, or even when things are going right in a patient with disease.
Well, Dr. Dubelman, you know, again, what amazes me is that patients will often be so concerned choosing their surgeon, and I think rightfully so. They want to go to a well-qualified surgeon. But then again, it's the anesthesiologist, say during a cardiac case, is totally responsible for monitoring the patient, keeping the electrolytes balanced, and actually restarting the heart, etc. Isn't that true?
Well, we work with the surgeon in restarting the heart. He will shock the heart. You have to have good communication, but while the surgeon's doing his intricate sewing, and as you know, some of this is microvascular like yours, pretty much, you have to maintain the chemistry of the patient. So.
Well, it's amazing to me how you guys monitor and watch the patient, make sure they're breathing right, etc.
And we have some new monitoring techniques in anesthesia, not that new, but transesophageal echocardiography, so we can now look at how the heart is beating before the chest is open, after the chest is closed, and while the chest is open as well.
I see. Now, Dr. Dubelman, there's a few specific questions I have for you. One of them is that we would like to explain to people the different types of anesthesia. I know there's a general anesthesia, there's a spinal anesthetic, there's what we might call a block, like a regional block, and of course there's pure local with sedation. Can we go through those for a moment and explain to our listeners and viewers the different types of anesthesia available?
Well, general anesthesia is the anesthesia that most people think of, and that means you're going to go to sleep.
Right.
Now, it's not really sleep, but you're going to be insensible to the pain, and you're going to be relaxed enough so the surgeon can operate on you. And that's the typical anesthesia. But there are many situations where what we call regional anesthesia or monitored anesthesia, IV sedation, are more appropriate. If you have if you have a finger problem and the surgeon can do a digital block, as I've seen you do many times, the patient just needs to be relaxed so that the block can be done comfortably, and then the patient can actually be relaxed and be awake during the procedure.
Okay. So we mentioned a general anesthetic. That's when the patient is so-called, as you say, so-called asleep. And you're giving them chemicals and drugs and medications to make sure that they're unaware and free from pain.
That's correct.
And then there's a sedation or a sedative. Some people call that twilight anesthesia, where you just get the patient comfortable, and then a local anesthetic is given by the surgeon.
That's correct, and that's dependent on the surgical needs and the patient, whether the patient wants to be awake or whether it's safe to have them asleep. There may be some situations where you're better off. I think if you or I had a laceration on our finger, for example, we would probably prefer not to be asleep.
Right.
On the other hand, if we had a large laceration up and down our arm from say, an automobile accident, I think we'd prefer to be asleep. It's a personal choice, and it's dictated by your general health situation, the skills of your surgeon, to some extent the skills of your anesthesiologist, and in many ways a conference between the three of them.
I see. Now, what about the so-called spinal? And you know, maybe you could tell us the difference between a spinal and an epidural for, say, a woman in labor, and then after that we'll talk about like an arm block or axillary block. What's the difference between a spinal and an epidural?
A spinal and epidural are very similar, but with a spinal, you actually have to go to get cerebrospinal fluid, and then you inject the drug directly into the cerebrospinal fluid. With an epidural, it's indirect, and you have to give far more drug, and it has to diffuse across the dura. The advantage of a spinal is that it has a more rapid onset, and it gives you, in some cases, slightly more complete sensory analgesia. But not in all cases. The epidural takes longer to come on, and it's slightly trickier in terms of performing it. But the advantage of the epidural is once you get the epidural in, you can put a catheter in, and you can make it continuous. So, for example, in labor, if a woman is going to be in labor for an hour and a half, and you know that, which often you can't really know that. You could do a spinal very well in most situations, very safely, and it would give her perfect pain control. On the other hand, if she lasts 8 hours, after the first 2 hours or 3 hours, you're going to need something else, whether it's a repeat spinal or an epidural. The beauty of an epidural is you can put a catheter in, and in most institutions, the woman can actually control her analgesia by pushing a button and giving herself more local anesthesia and narcotic.
Okay, so Dr. Dubelman, I think that's a great point. Now, but let's define for our viewers and listeners what you mean by a catheter. That's a very fine little tube.
It's a very small tube. In our situation, it can be of varying sizes depending upon where you put it. But in the epidural space, it's probably about a millimeter and a half. And it fits through the needle and goes into the epidural space. And a catheter is a hollow tube where we can infuse medications.
Okay, so I've been led to believe that anesthesia has almost revolutionized childbirth with things like epidurals and taking care of women in childbirth, as compared to, say, 50 years ago. It was a totally different event to give birth in the hospital. Is that true?
I think that's absolutely true. And in many institutions, I think the rate of epidural administration for patients who are in labor is over 90%. And patients have come to expect that they can get an epidural to make them more comfortable.
I see. Okay. Dr. Dubelman, again, one of the concerns I hear in my office as a plastic surgeon, I can be counseling a person about options for anesthesia for a facelift or for liposuction or to fix their hand, etc. They're concerned about anesthesia, and they say to me, what if I start talking and tell stories or give away secrets? And then some people say, what if I'm in pain and I can't move and speak up? I mean, how about those concerns about so-called awareness and people they're concerned that they're going to get a truth serum?
Well, I think that outside of the Central Intelligence Agency using our drugs as a truth serum, I've been in practice for 29 years, and I would say it's not easy to do. So I think that's not really a great concern for the patient. In terms of being aware in anesthesia, this is a hot topic. There was a recent movie that I'm told was quite poorly reviewed and nobody saw it, about a patient being awake during anesthesia. Can it happen? Yes, but the incidence should be less than 1 or 2 per 1,000 and far less in most situations. The situations where it's most likely to occur are cardiac anesthesia, when we have a very weak heart and we're afraid to give more drugs. Trauma, where the patient is bleeding to death and we figure if we give them drugs, it may actually tip them over the edge so they can't be resuscitated. And OB anesthesia, if we do a general anesthetic for, say, a cesarean section. We do almost none of those anymore because we know that regional anesthesia, by that I mean spinals or epidurals, are much, much safer. Up to general anesthesia in a lady for a C-section is up to 17 times as dangerous in terms of the patient dying. So it would only be the most unusual situation, which would be an emergency where you had to get going right now, or a patient who had a coagulopathy or a bleeding tendency where they couldn't tolerate a spinal or an epidural, where we would even consider general anesthesia. In fact, in modern training programs today, they do so few of them that they have to have simulators so that residents can learn how to do a general anesthetic in OB. I
see. Dr. Dubelman, you mentioned something about the trauma patient, which means a patient that comes into the emergency room badly injured. I'm always amazed at the scope of the anesthesiologist, how it seems to be expanding. I know you guys are called to the emergency room sometimes to run codes, or when a person's heart is unstable or stops. I know some anesthesiologists actually run the ICU or intensive care unit. Isn't that true, that it seems to be your scope is expanding? You can go to the emergency room, you can obviously stay in the operating room, or you can help to run the intensive care unit.
No, that's correct. In California, there aren't that many anesthesiologists who run intensive care units, but in other states, there are more. And I actually went into anesthesia originally because I was interested in intensive care, but then the heart waylaid me.
Yeah. So at what point did you start to get interested in cardiac anesthesia?
Well, I wanted to be a cardiologist when I did research with a few very prominent cardiologists in Southern California. Dr. Swan, who has passed away 2 or 3 years ago, developed a special catheter for the heart, the Swan-Ganz catheter.
Right.
And he was my advisor in medical school. I always wanted to be a cardiologist, but then I practiced in Alaska for a short period of time and got interested in intensive care, and that's how I got to anesthesia. And actually I thought, well, gee, maybe I'll do both, but it didn't happen. But I got the best of both worlds because I got to do cardiac anesthesia, and I've enjoyed it.
Great. You know, for a brief time, before I went into plastic surgery, I considered anesthesia because I thought it would be great to teach pharmacology and physiology at a medical school, and then also to have a clinical practice at the hospital. Because I know a lot of the anesthesiologists, they just love physiology and pharmacology.
That's right, we did.
So at times, you talk to a patient before the operation, and you help them decide if they're going to get a general anesthetic or a block or a regional or a sedative anesthetic. Tell us how you help a patient to decide what they're going to get for anesthesia.
Well, there are some situations, for example, open heart, where the procedure mandates a general anesthetic. There are others, and others, even laparoscopy, where they put a tube in the abdomen. Those are, you have to have a general anesthetic for those. There are others where there's a choice, and it depends on the patient. If the patient says they want to be awake, for example, in a knee arthroscopy that Dr. Gerbino might do, although it's not typical, usually we would put that patient to sleep if they wanted to be awake. If we're going to be able to keep them comfortable and safe, we would do that. For plastic procedures of the face, if we think the patient can be comfortable and the patient has the appropriate sense of calmness, I think we would do it there, or we could put them to sleep if they wanted to be asleep.
I see. Well, Dr. Dubelman, I want to compliment you, and I hope our listeners and viewers know this, that I have great confidence in your work, and you've always just done a terrific job monitoring people and keeping them comfortable and out of pain and making sure their heart's going just right. So I really appreciate you being part of our medical community. Thanks very much for coming on the program. I'm Dr. David Morwood. I'm a board-certified plastic surgeon, and this is Your Health radio and television program, and that was Dr. Alex Dubelman of anesthesia. We're going to take a very brief pause for a good cause. We're going to come back with my next guest, Vicki Torrey, surgical nurse. Thanks very much for being here. We'll be right back.